Good morning, ladies and gentlemen. The topic of today is Morphea and Allied sclerosing dermatosis. Definition and nomenclature. Morphea is characterized by varying degree of sclerosis, fibrosis, and atrophy of the skin and subcutaneous tissue, which sometimes extends deep into the muscle, bone, and even brain in specific areas. Extracutaneous manifestations are rare in Morphea, but can be seen in up to 25% of the cases. But there is usually no internal organ fibrosis or vascular changes as we see in systemic sclerosis. Anti-nuclear antibody positivity is common, but specific autoantibodies seen in systemic sclerosis are not seen. There is no increased mortality in Morphea, but there is substantial morbidity, which occurs due to joint contractures, facial and limb asymmetry, extracutaneous manifestations, and the psychological impact of the disease. Terminology. In spite of the term local scleroderma, which is confusing, Morphea is a preferred term to describe the skin condition that is associated with limited or diffuse involvement or diffuse involvement of the skin, but not involving any internal organs like lung, heart, and kidney. There are various classifications of Morphea mentioned in the textbook, but the following is the most balanced and most valid classification. And I think that we should follow this classification. This classification divides Morphea into the limited type, the generalized type, and the linear type, with the fourth subclassification as mixed Morphea. The limited type of Morphea include the limited plaque Morphea, the Guttate Morphea, Atrophoderma of Pasini-Pierini, keloidal and nodular Morphea, and limited deep Morphea. The generalized type of Morphea include disseminated plaque Morphea, pan-sclerotic Morphea, and Eosinophilic fasciitis. Then the linear type of Morphea is again subdivided into head and neck variant and trunk and limb variant. The head and neck variant has the Morphea and coup de sabre and progressive hemifacial atrophy. While the trunk and limb variant include the linear Morphea, the linear Atrophoderma of Mollin, and linear deep atrophic Morphea. And lastly, the mixed Morphea with lichen sclerosis with Morphea associations. So we will be discussing the individual types in the following sections. The generalized Morphea is used as an umbrella term for patients with widespread disease. It encompasses the disseminated plaque Morphea as well as a group with pan-sclerotic lesions. These are the few terminologies which you should remember. The deep Morphea implies involvement of the deep dermis, subcutaneous fat, fascia, muscles, and sometimes bone. Lesions may involve any combination of the structures, and the skin is poorly defined as bound down and may have pewdy orange or cobblestone appearance with guttering along the vessels and tendon. Since the vessels run over the bones, if the skin is tethered to the bone, then it will give this impression that is guttering along the vessels. Similarly, the bullous lesions can occur in any subtype, and usually it signifies active inflammatory phase of the disease, and the bullous lesions are most frequent on the lower limbs. Introduction and general description. Morphea has a common underlying pathophysiology of increased collagen deposition in an autoimmune setting. It is largely confined to the skin and subcutaneous tissue. including fat, fascia, muscle, bone, and joints. 1/5 to 1/4 of the patient experience extracutaneous manifestation that include the musculoskeletal, neurological, ocular, vascular that may include Raynaud's and GI complications. Autoantibodies such as anti-nuclear antibody, anti-histone, anti-single-strand DNA may be present, but scleroderma-specific autoantibodies like anti-topoisomerase, anti-centromere, and anti-RNA polymerase are rarely found. So in general, we can assume that Morphea is purely a skin disease with involvement of underlying fascia and muscles and even bone. And there are minimal internal organ involvement, and most of the autoantibodies associated with scleroderma are absent. It is distinguished from systemic sclerosis by absence of sclerodactyly and nail fold capillary changes. So this will always be the differentiating point for you in your clinic and exam. The internal organ involvement, namely pulmonary fibrosis and pulmonary hypertension, hypertensive renal crisis, and infiltration of GI do not occur in Morphea. Previously considered as self-limiting condition, but which is true in most of the cases, but now there is evidence of protracted, relapsing, and remitting course in some patients. The bullous lesions can occur in any subtype of Morphea in context with active inflammation, and they can be of significant cosmetic and functional sequelae. Even though there is no increased mortality, significant morbidity occurs, which I have already explained due to facial and limb asymmetry, flexion contractures, and psychological disability. Like in systemic sclerosis, the Morphea lesions evolve as the inflammatory, then active phase, followed by sclerotic phase, and then atrophic changes. The key to successful treatment involves initiation of treatment during the active inflammatory stage before the sclerotic changes sets in. Incidence and prevalence. Age. This disease can occur at any age, but 75% of the plaque Morphea occur at around 40 to 50 years. However, the 75% of the linear disease occur in ages between 2 to 14. Female-male ratio is 2.6 to 7:1. Adult pan-sclerotic Morphea appear to be more common in males. As far as the subtypes, the plaque Morphea is the commonest type of Morphea, accounting 56% of the total cases, followed by linear in 20%, and generalized in 13%, and deep in 11% of cases. Associated disease. Other autoimmune diseases like vitiligo, psoriasis, alopecia areata, primary biliary cirrhosis, type 1 diabetes, autoimmune thyroiditis, celiac disease, SLE, and rheumatoid arthritis are all associated. Concomitant rheumatic or autoimmune disorders were identified in 18% of the patient. This association was most marked among adults and children with generalized Morphea, occurring in 46% of this group versus 9% in other subtypes like limited or linear Morphea. The offspring of patients with Morphea are at greater risk of developing rheumatoid arthritis. Then something about LSA and Morphea overlap. Cases of LSA occur in conjunction with Morphea. In a study of 472 Morphea patients, LSA was identified in 5.7%. In another study with 76 Morphea patients, 38% were found to have genital LSA as compared to 3% in the control. So it means that LSA Morphea association is a common association. Given the known risk of SCC in genital LSA, genital examination is mandatory in all patients with plaque or generalized morphea. The relationship between the two diseases is still in question, and it is argued by some that LSA is a superficial subepidermal form of morphea. So the point here is always examine or ask for the examination of genitals in patient of morphea. Clinically, the distinction between classical plaque morphea, that is thicker, larger plaques with peripheral inflammatory lilac ring, and LSA, the porcelain-white papules and plaque with varying degree of follicular plugging, erythema, telangiectasias, purpura, sclerosis is always possible. Difficulties can also occur trying to distinguish the two conditions histologically. And the histological differentiation is mainly by the follicular plugging, which is seen in LSA and not seen in morphea, and the lichenoid infiltrate, which is seen in papillary dermis in LSA, which is not seen in morphea. The loss of elastic fiber also favors LSA. Pathophysiology. The predisposing factor to morphea include trauma, which include the vaccination for hepatitis B, MMR, BCG, and diphtheria, infection like Borrelia, post-radiation, and medications like Bellicativ. Autoimmune profile. ANA is positive in 18 to 68% of the cases, anti-histone antibodies in 12%, SCL 70, 3.2, anti-centromere 1.7. So if you have to order any antibody, it would be anti-nuclear antibody. Antibodies to fibrillin 1, to MMP1, which inhibits collagenase activity, are identified in patients with linear plaque and generalized morphea. Immunopathology. It is proposed that Th1 cytokines, which are interleukin-2, 6, and tumor necrotic factor alpha, are activated during early inflammatory stage of morphea. Then it is followed by Th17 effectors, which include interleukin-17, interleukin-22, and transforming growth factor beta. This interleukin-17 effectors propagate the inflammation and initiate fibrosis. Then comes the Th2 cytokines, interleukin-4 and 13, which signifies the occurrence of fibrosis and further damage. So immunopathology is interesting that Th1 cytokines are involved initially, Th2 cytokines are involved later, and in between Th17 effector cells are important. Th1 cytokines in active disease, Th2 once the damage occurs. And the early features include erythema and newly enlarging skin induration, while the late features is skin thickness, dermal atrophy, subcutaneous atrophy, and dyspigmentation. Although the vascular damage is very early feature in systemic sclerosis, this is less well studied or found in morphea. Endothelial swelling and apoptosis have been identified in early morphea lesions. Direct damage through trauma, infection, and radiation is contributory factor in many cases. The cytokines indicating inflammatory damage and fibrosis in morphea, vascular cell adhesion molecule 1, intercellular adhesion molecule 1, E-selectin and interleukin-8 indicates the vascular activation. Interferon gamma inducible protein 10, interleukin-2 objectively measures the disease activity. Then interleukin-6, 4, 13, and tumor necrotic factor alpha, interleukin-17F are inflammatory and fibrokinetic cytokines. So these cytokines, if measured, indicates the vascular damage or the inflammation, but these investigations are not routinely performed. Fibrosis is thought to result from a combination of increased collagen deposition by the fibroblast and reduced extracellular matrix turnover in morphea. That is, collagen is formed, but it is not scavenged or removed. And hence type 1 and type 2 collagen messenger RNA and protein expression has been identified in morphea fibroblasts. Glycosaminoglycans and fibronectin synthesis is also increased. Skin biopsies and sera of morphea patients have demonstrated increased transforming growth factor beta expression and co-localization with active fibroblasts. CD34 positivity is lost and factor 13A expression is increased in area of fibrosis in morphea. Just as a passing remark, CD34 is the marker of dermatofibrosarcoma protuberance and factor 13A a marker of dermatofibroma. Histopathology. The morphea is characterized by thick dermis with dense collagen bundles and perivascular inflammatory infiltrate, which is seen in early lesions. There is epidermal atrophy, but no significant follicular plugging. The collagen fibers are eosinophilic and swollen. Hair follicles and sebaceous glands are characteristically absent, while the acrine ducts are seen trapped between the collagen bundles. If we do Mason trichrome stain, which is a stain for collagen, then it highlights the fibrosis in morphea. And if we do elastin stain by von Giesen, then there is loss of elastic tissue in morphea lesions. And this loss of elastic tissue is more in LSA as compared to morphea. Once the patient enters into the sclerotic phase, there is little inflammation, but the collagen bundles are thick and hyalinized and oriented horizontally. Dermal appendages and subcutaneous fat is progressively lost. The deep morphea. The deep morphea involves the deep dermis and going into the subcutaneous fat, which is replaced by wavy fibers and newly formed collagen. This collagen is rich in type 3 variety. So deep morphea involved the subcutaneous fat. Features that favor morphea over systemic sclerosis in histopathology, that is more intense inflammation in morphea, presence of perineural inflammation, and more diffuse dermal sclerosis simultaneously involving the papillary and deep dermis. So inflammation is more, the fibrosis is more in localized morphea as compared to systemic sclerosis. Role of Borrelia in inducing morphea. This role is controversial. So the points in favor are the clinical and histological similarities between morphea and acrodermatitis chronica atrophicaans. Then finding that LSA was observed to coexist with Atrophoderma chronica atrophicaans in 12% of the cases, and it also coexists in morphea. The response to certain cases of morphea to antibiotics. So points against the role of Borrelia in morphea is that a wide range of diagnostic tests used that include immunoperoxidase, silver stain, focus floating microscopy, tissue culture, serology, and PCR to identify Borrelia DNA, and only found in 1 in 49 cases of morphea. So this one can be coincidental. Genetics. Recently, association between HLA-DRB1 and HLA-B37 has been demonstrated, particularly in linear and generalized subtypes. Trauma and vaccination. Due to vaccination of hepatitis B, MMR, diphtheria, tetanus, pertussis, pneumonia, and BCG, morphea can be induced. Onset after injection with vitamin B12 and vitamin K. It has been suggested that morphea may reflect an immunological response triggered by the vascular injury and tissue hypoxia as a result to trauma at the injection site. The potential role for trauma in development of linear morphea is also considered. Skin lesions occurring at the site of repeated concurrent trauma, referred to as isomorphic response of Koebner. So if the morphea occur at the site of repeated trauma, it is called as isomorphic response. Isomorphic patients are those in which the lesions distributed exclusively in area of friction. The radiation and drugs. Most cases of morphea develop within the radiation field, but in 20 to 25% of the cases, it extends beyond that. Development of morphea in 9 patients on high dose of bellicatab, since the drug inhibits the collagenollytic activity. History. The onset and progress of morphea is insidious, slow and steady. Patient may describe changes in skin texture or color first, then itching, pain, or numbness. When lesions extend across the joint, then there is reduced mobility, contractures, and limb girth and length discrepancies. The linear disease results in asymmetry of the facial features, alopecia, indentation or grooves in the skull, ocular pain, dental abnormalities, headache, and seizures. In generalized subtype, fatigue, myalgia, and arthralgia are frequent manifestations. Presentation. Presentation are benign with erythematous, edematous, and inflammatory phase, lateral central sclerosis, and surrounding thickening and waxy yellow-white looks. There is the morphea lesions are surrounded by a faint lilac ring, which is more obvious in fair-colored individuals. There may be loss of hairs and absent sweating because of effect on adnexal structures. Over months or years, lesions become atrophic and hyper or hypopigmented. So initially, the lesions will be edematous and inflammatory, which will be manifest as erythema. Then later on, the lesions will become sclerotic, that is thickened, then become atrophic with pigmentary changes. Depending upon the depth and type of lesions, changes in subcutaneous muscle, fascia, bone, and underlying brain may be present. So this is the characteristic white sclerotic plaque of morphea with a characteristic lilac colored border. The limited type of morphea. The limited plaque morphea, which is the commonest form and which presents with round or oval lesions more than 1 centimeter in diameter in up to 2 of the 7 anatomical sites. The 7 anatomical sites include the head and neck, which is the one side, then both upper limbs are 2 more, both lower limbs 2 more, and then anterior and posterior trunk. So these are the 7 sites, and in the 7 sites, we see more than 1 centimeter lesions, which is up to 2, not more than 2. Plaque morphea with deep involvement. So you can see the plaque with deep involvement of the subcutaneous fat and fascia. The second type of limited morphea is the Guttate morphea. The Guttate morphea is characterized by multiple small, less than 1 centimeter. The limited, the previous type, the plaque morphea had more than 1 centimeter. This is less than 1 centimeter. Erythematous through yellow-white, mildly indurated lesions, most frequently on the trunk. Lesions are superficial and may have shiny crinkled surface, clinically resemble lichen sclerosus, but lesions generally resolve, leaving hyperpigmentation. While in LSA, there will be follicular delling or plugging, which is not seen in Guttate morphea. And the LSA lesions are not easily resolved, and they lead to variable degree of hypopigmentation. Atrophoderma of Pasini-Pierini is another limited form of disease, which present 0.1% of childhood morphea and usually occur in adolescence and young adult life. There is symmetrical distributed truncal or zostriform lesions. The lesions are typically non-indurated, blue-gray to brown in color, with sharply depressed margins, which are described as the cliff drop appearance. That is a sharp, as we see a sharp dip in a cliff drop, then this will give a cliff drop appearance. The inclusion of Atrophoderma of Pasini-Pierini within the spectrum of Morphea is supported by coexistence of area of induration, more typical of Morphea in some of these patients. You can see this Atrophoderma of Pasini-Pierini. The lesions are usually not as sclerotic and as atrophic as Morphea, but sometimes among these multiple lesions, you can find a typical lesion of Morphea. The keloidal or nodular Morphea. This is a rare subtype that is characterized by the presence of keloid-like nodules in patient with previous or coexistent Morphea, or in majority of cases of systemic sclerosis. There is a histological appearance typical of either keloid or Morphea. Lesions are most common on the upper body, where they may coalesce or occur in a linear pattern. So this is the keloidal lesions in a Morphea. And on histology, among the histology of Morphea, you can see the localized area with more hyalinized collagen. The limited deep Morphea, which is also called as the Morphea profunda. The deep Morphea describe a variant in which inflammation and sclerosis are found in deep dermis, panniculus, fascia, and muscle. The Person and Sue diagnostic criteria of Morphea profundus is the presence of diffuse, taut, bound down, pewdy orange appearance with deep cutaneous sclerosis. So usually the normal Morphea is not so bound down with pewdy orange appearance, but Morphea profundus is. Histology, there is significant hyalinization and thickening of collagen bundles in deep dermis, septa of subcutaneous fat, and in fascia with a striking accumulation of inflammatory cells, which are composed predominantly of plasma cells and lymphocytes. Rare plasma cell panniculitis have been described as a synonym, that is Morphea panniculitis, in children and adult. Occasionally, lesions present as non-inflammatory, capelliform, depressed plaque. Deep Morphea can mimic lipoatrophy clinically and should be considered in patients presenting with asymptomatic atrophic lesions. Now the generalized type of Morphea. Falenga suggested 5 or more bilateral lesions and evidence of joining together of at least 2 individual plaques. So the criteria of Morphea include presence of 5 or more lesions similar to the limited type, and 2 of the lesions should be coalescing. Loxer and Zulin defined it as induration of skin starting as 4 or more individual plaques, the larger than 3 centimeter in diameter, and becoming confluent and involve at least 2 out of 7 anatomical sites. So in one criteria, it is 5, and in other criteria, it is 4, and size should be more than 3 centimeter, and at least 2 should be coalescing. And that involve at least 2 of the 7 anatomical sites. The 7 anatomical sites I've already mentioned: the head and neck, both upper limbs, both lower limbs, anterior and posterior trunk. So at least 2 areas should be involved to call it as a generalized Morphea. There will be extracutaneous symptoms like myalgias, arthralgias, fatigue, dyspnea, and dysphagia, and high prevalence of concurrent and familial autoimmune disease. The disseminated plaque Morphea. The patient gradually developed multiple plaques of morphea at several anatomical sites, often symmetrically distributed and coalescing. Most frequent sites are the trunk, thigh, and lumbosacral area. Both adult and children initially presenting with limited plaque morphea, which may progress to fulfill the criteria of generalized morphea. So limited plaque morphea can convert into a generalized disseminated type of morphea. So the lesions are seen in anterior as well as posterior trunk, and the lesions are larger in size and coalescing with each other. Then another type of generalized morphea is pan-sclerotic morphea. This is a rare presentation and is characterized by extensive and often circumferential involvement of majority of the body surface area, but sparing the finger and toes. The term has traditionally been used to describe a widespread and severe progressive disease occurring predominantly in children, in which deep fibrosis progress rapidly to involve muscle, fascia, and bone, and this disease was labeled as disabling pan-sclerotic morphea of childhood. So the word disabling was added in this variety. This frequently complicated by severe joint contractures, chronic ulceration, and development of squamous cell carcinoma. Because of relative ambiguity as regard the depth of involvement and criterion of deep tissue involvement, including the subcutaneous tissue, muscle, and bone, was removed from the criteria of the pan-sclerotic morphea. And now the criteria that holds for pan-sclerotic morphea is the presence of near total body for surface involvement, but sparing of toes and feet, toes and fingers. Most patients had a more rapidly progression. Interestingly, there is no significant difference between the generalized morphea and pan-sclerotic morphea. However, patients with pan-sclerotic morphea are more likely to be male, 47% as compared to 6%, have a shorter time to diagnosis, higher functional impairment, 61% versus 16%, and higher skin sclerosis and damage scores. So pan-sclerotic morphea is more common in male, have shorter time of diagnosis, there are more chances of functional impairment and damage scores. So this is the pan-sclerotic morphea. You can see that the skin is more bound down as compared to skin in generalized morphea, with D-shaping of the structures. Eosinophilic fasciitis is a third type of generalized morphea. Its synonym is the Shulman syndrome. The disease symmetrically involves the extremities, particularly the lower limb, but typically spare finger and toes. So this disease is not involving the trunk mainly. However, truncal lesions are described and can have a considerable overlap with pan-sclerotic morphea, but generally the eosinophilic fasciitis is assumed to be involving the limbs. Unaccustomed severe exercise may precede the onset of disease, and the disease starts with painful burning erythema, pitting edema of limbs. This is replaced by induration and fibrosis and pewdy orange appearance of the skin with teething around the vessels, producing the typical guttering called as the groove sign. So start with erythema and burning, then pitting edema, then pewdy orange appearance of the skin with thickening and a groove sign around the blood vessels. So this is the thick bound down skin of the limbs. A deep biopsy is necessary to diagnose eosinophilic fasciitis. A biopsy should include the subcutaneous fat because the epidermis and papillodermis and adnexa are not affected. The chronic inflammatory infiltrate extend deep into the subcutaneous fat, And the infiltrate is comprising mainly of lymphocytes, then plasma cells, and then a large number of pink-colored eosinophils. There is fibrosis and sclerosis of subcutaneous fascia. Disease results in severe joint contractures, which are associated with morbidity, high ESR, and C-reactive protein, hypergamma-globulinemia, and peripheral eosinophilia, which may be present in 60 to 90% of the cases. Hematological abnormalities include thrombocytopenia,